Now, they won't say to you, you know, doc, I think I might be anhedonic today, right? They're going to say to you, I don't know, I feel depressed, I feel irritable, I'm bored, I don't get any, you know, I mean, that's the way they describe it. It means they're dopamine depleted, dopamine deprived. And we need to know if they're suffering cognitive impairment. Can they count to 20? Can they count backwards from 100 by sevens? Hey, you guys try that after this, okay? Try it, okay? You know, can they spell the word world backwards? Can they do simple arithmetic? Can they pay attention? And if the answer is no, they are cognitively impaired. This is what we must know in order to know whether use is compulsive, whether the person needs medication or not, and we never ask the questions. Not ever. So at the first contact, which will very often be either the police arrest contact, or it'll be at booking, or it'll be in jail, or it'll be at the bail release, you need to know whether the person meets criteria, is likelihood of suffering an overdose. I'm just giving you here some very examples of some very short, a few questions, 3-4 questions that clinicians should be asking them. And if they are not, they are incompetent, okay? An incompetent clinician would never ask these questions. Have you overdosed before? Okay? How many times have you witnessed an overdose? Are you experiencing or have you experienced withdrawal? These aren't the only instruments. These are just instruments that are free and have a small number of questions that you can ask. And I'm here to tell you that if you are dealing with people with opiate involvement and you are not asking these questions, you are engaged in incompetent practice, okay? If I'm a judge and somebody had a positive drug test and you come to me, probation officer, and you tell me you want to revoke that person's probation because they had a positive drug test, the question you're going to get from me, and I'm not a judge, it's a fantasy, but the question you're going to get from me is your patient, is your client clinically stable? When's the last time he experienced cravings and withdrawal? And if you don't know the answer to that question, then you should not be petitioning for a revocation, okay? Go find out the answer to that question, because I don't know what to do until I know whether the person is clinically stable or not. Cravings. The person suffering cravings. These are the scales that competent physicians use to find out whether their clients need medications. The reason that we don't use these instruments is because we don't work with physicians typically. We work with non-medical practitioners. They're not familiar with these tools and they don't use them. But now, in the midst of an opioid crisis, get familiar with them or go work with a different population. We need to know if the person is suffering anhedonia. Some of these instruments are one question on whether the person is suffering anhedonia. Cognitive impairment, okay? This is the kind of stuff that we need to know, and we don't just ask it one time at arrest, because at every point, when treatment says, I think it's time for this person to be released from the 28-day program and go to outpatient, what's the first question you ask? Is the client suffering withdrawal, craving, anhedonia? Is the client still cognitively impaired? When probation comes to you on a revocation, your first question is the patient suffering withdrawal, cravings, anhedonia? Is they cognitively impaired? Because you can't select an evidence-based response without knowing the answers to those questions, okay? Now, treatment providers, and here when I use the word treatment providers, I'm really talking about the typical treatment staff working with probation and the courts, which are not usually nurses or physicians. Okay, it's very rare for nurses or physicians. They're going to be psychologists, even that fairly rare. Social workers, addiction counselors. What do they need to do in order to be minimally competent in their jobs? The first thing they must do is get a diagnostic assessment of substance dependence or addiction, okay? I did not say give somebody a screening tool, the SASI, or the Addiction Severity Index, or any of those kind of things. Doing a diagnostic assessment to determine whether that person meets diagnostic criteria for substance dependence or addiction. And I can tell you that 85% of participants in substance abuse treatment involved in the criminal justice system have never received an accurate diagnosis. Ever. The clinician did it based on their impression. Okay? I met with the person, I talked to them, alcohol dependence, okay, or polysubstance dependence. 14% receive diagnoses that don't exist, okay? Diagnoses that are no longer in or never were in the Diagnostic and Statistical Manual of Mental Disorders, like polysubstance dependence, which is not even a diagnosis. Okay? If your clinicians are not competent to diagnose, they're not competent to treat. Say it again. If you're not competent to diagnose, you are not competent to treat. The ultimate question, which should be communicated from the clinicians to the criminal justice system at all times, is this person's substance use substantially compulsive or willful? Okay? It's never all one or all the other. But was this use a result of cravings, withdrawal, compulsion? Or was this a willful, proximal infraction? And if your clinicians can't answer that question, then they cannot make a recommendation to you about how to treat this case. Okay? Every conversation is diagnostic, and was the infraction proximal or distal, willful or compulsive? Then the treatment providers are going to need to do something called a level of care assessment to determine if the person needs medication-assisted treatment and whether it needs to be medically managed or medically monitored. I'm now speaking to the criminal justice people in the room. This is how you'll know if you're getting good care from your clinicians. If they have not used a structured diagnostic tool to render a diagnosis, you're getting substandard care. If they have not done an ASAM, American Society of Addiction Medicine, patient placement assessment to determine whether medications and medically monitored treatment is appropriate, if they have not done that, you are not getting competent care, okay? And therefore, you cannot move forward on the basis of that care, okay? It cannot and should not form the basis of a treatment plan, especially in the court system. Okay, I would say in any system, but especially in the court system. Now, I see a lot of deer in headlights right now, and I should, because I will bet my next year's salary against yours that less than 10% of the people that you are dealing with life-threatening illnesses, with their liberty, their future, everything at stake, have never received what would be even considered a minimally competent assessment prior to intervention, okay? We want to be treated like a profession, then we need to act like a profession. Once the treatment providers have done their assessment, they then have to get informed consent from their patients. An informed consent means that you must inform your patient of all material facts related to their care. Material facts are facts that an ordinary, reasonable person would want to know before that person decided on what treatment to undergo, which means you must tell that person the risks and benefits of the treatment you're recommending, the risks and benefits, or the likelihood that it'll be successful, the risks and benefits of alternative conditions for the same treatment, and the likelihood of success. This is a minimal ethical legal requirement of anybody providing treatment. Everybody with me? Okay? Which means you can say, we don't believe in MAT. You're allowed to believe anything you want to believe. Okay? We're a treatment program. We follow certain principles. We don't use MAT. But in order for you to get informed consent to treatment, you must tell your client that the odds of success in drug-free counseling are less than 5%, and that the odds are many times higher if they receive medications. If you have not told them those facts, then you have not gotten informed consent. If you have not gotten informed consent, you have committed malpractice, okay? Now, we never worried about this in the past because we never really had a standard of care in the substance abuse world. We called ourselves a profession, but we were really a paraprofession. And we acted like a paraprofession. We had no standard of care, we had no protocol, we had no guidelines. But nowadays, we have protocols, guidelines, and malpractice principles can and do apply. Now, there are probably some people in this room saying, well, but the judge tells me I have to put them in here. This is, they're part of the, I'm working with probation. This is what everybody gets. Well, the judge has what's called absolute immunity, okay? You have what at best would be called qualified immunity, which means immune from prosecution only if your behavior, although falling below the requisite standard of care, was not grossly below the standard of care and not in direct contradiction of explicit requirements in your field, okay? In other words, the judge is going to walk away scot-free, treatment providers, but you will not, okay? You do drug-free counseling with an opiate addict, you don't tell that person about medications, inform them of it, get their informed consent, then you have engaged in malpractice. And the fact that you're working with a judge does not put you under the judge's skirt, okay? This is on you. And there are lots of people out there looking for test cases now that they weren't there 5 years ago. They weren't there 10 years ago. But they're waiting for that patient to die. They're waiting for just the right fact pattern to come to you and ask you why you treated someone with a long history of opiate addiction without medications. And you never told them about their options. You never talked to the judge about those options. You never advocated for those options. You have a ethical and standard of care responsibility to treat or refer for services as indicated. So if your assessment of the risk-benefit ratio is that medication is the indicated treatment, then you either provide that indicated treatment or you refer to someone else who can, or you get the patient's explicit waiver that they do not want the standard of care, they want what you guys are offering, okay? That's your requirement. And you are not allowed to say, well, I don't know anybody who provides medication. That's not who we work. We only work with, our own program here. We don't have referral sources. We don't know who the physicians in our community are. That's not an option. Imagine going to a doc, you go to your primary care physician, and he says, I think you might have cancer. And you say, oh my God, please refer me to an oncologist. And he says, sorry, I don't know any. Right? And that sounds ridiculous. And yet we do it all the time. We only know what we give. You have an affirmative obligation, if you call yourself a professional, you have an affirmative obligation to be able to assess, determine the appropriate care, and refer if necessary. If you don't have a referral network, you are engaged in substandard practice. An unreasonable failure, and unreasonable just means you don't have a really good reason. An unreasonable failure to identify the need for medications. You didn't even look or assess for the possibility the person needs medication. Or to obtain informed consent, or to refer the person for appropriate services is the definition of malpractice, okay? That is malpractice. Now, a lot of people are going to tell me, well, what do you want from us? We're in rural communities. We can't find anybody who does this. Yes, you can. There are all kinds of websites out there, physician locator websites, where you can put in zip code, towns, find physicians, local universities, private practice, and the like, who are engaged in and can offer medications. And if you can't find it in your community, you work with these organizations to get distance recommendations and for them to reach out and try to locate and train providers in your community. If you went on these sites, you did this and you couldn't find anybody, then you have taken reasonable measures, you did the best you could, you're off the hook. If you didn't bother looking on these sites, If you didn't find out in fact whether there are competent medical providers, then you did not do your ethical responsibility, your clinical responsibility as a healthcare professional. Physician obligations. So if somebody has been screened, they're identified as having issues related to addiction, they are assessed by your treatment team, they are clinically assessed as being meeting criteria for dependence, their use is compulsive, it's an opioid disorder, you think that medication is the appropriate standard, then you refer to the physician. The physician must confirm the diagnostic and level of care and pressure. So the physician is going to independently determine that he or she agrees with your assessment. Then the physician is going to make a reasoned judgment about treatment course. Now, I'm going to get into this a little bit more in a bit, but a reasoned judgment means you have to have a good reason for choosing the medication you chose, all right? So that's the only, I only do buprenorphine is not a reasoned choice. I only do methadone is not a reasoned choice, okay? There are factors the physician must take into consideration in deciding. You must explain your recommendations to the patient and the supervising criminal justice authorities. Let me be clear about that. If a case has been sent to you, physicians, by the criminal justice system, and the patient has executed a waiver and a consent to share that information with you, and it is a condition of a criminal justice alternative disposition, you have no option but to share that information with the criminal justice system, because that information does not belong to you. You do not own confidentiality, the patient does. And if the patient has waived that confidentiality according to a duly executed form, then you have no option but to share that information, subject to certain restrictions, such as it must be information reasonably or minimally necessary to meet the needs of the criminal justice system. So what is minimally necessary? A diagnosis. What's your diagnosis, doc? Why did you choose methadone instead of buprenorphine? Doc has to give a reasoned answer to the question about the choice of medication, the treatment plan. Doesn't mean you say, you know what, I disagree with you, so I'm going to overrule you. That's not what I said. It's just the doc explains it to you so you can do your job by understanding what care the patient is receiving and why. Do you need to know the patient was sexually abused by her uncle when they were 3? Probably not. Probably not relevant. Maybe under some circumstances it might be, but most of it's going to be around the choice of medication, the medication regimen. Now, docs in the room, let me tell you the one thing that judges hate a lot is when they ask you a question and you answer the question with a question, or you answer the question with some smart aleck remark, all right? So I hear this painful interaction all the time where the judge asks the doc, how long is he going to have to be on this methadone? And what answer does he get? Well, doc, judge, there are several factors that I'll be considering, and the average, what's the usual answer they get? As long as it takes. Some people will have to be on these medications forever. Right? You don't ask people who are, who have high blood pressure how long they're going to be on their blood pressure medication. Why are you asking me? Now, there's one group of people that is more arrogant than docs, okay? And that's judges. And so I tell docs, don't be a wise ass with a judge. If you get asked a question, answer it. And if you don't know the answer, then go away and rethink it before you. Because many of the times, the reason they come up with those smart aleck replies is because they don't know the answer. They never really thought about why they chose the medication they chose. And you have a right, the criminal justice system, to ask them to justify their decisions. They have to report on treatment adherence, response to treatment, and medication adjustments. If you change the medication, you tell the criminal justice system. Tell them you did it and why. If you take them off it, you tell the criminal justice system you did it and why. If the patient is responding and doing well, if the patient is not responding, it is your responsibility to share that information with supervising authorities. If you don't, you're more likely to be overruled, and you're more likely to have the judge or the criminal justice system get in the way of your treatment. And then you'll complain about how the criminal justice system is practicing medicine without a license, and they'll complain how you were an incompetent doc who never answered any questions, and that's where we are today, with the two professions constantly yelling at each other. You have a responsibility to respond to inquiries concerning possible side effects. If the treatment team calls you, doc, and says the client is nodding out in therapy groups, your answer is, okay, let me meet with the patient and see if the patient's over-medicated. Or I'd rather wait 24 hours because I just increased the dose. If he still seems to be nodding out tomorrow, then I'm going to reconsider it. You have an affirmative obligation to respond to their concerns by doing something, okay? And answer their questions. And ideally, provide in-service trainings to criminal justice staff on MAT. In other words, train the criminal justice system about these medications. Explain how they work, why you're doing what you're doing, okay? These are the requirements of a physician working in the criminal justice system. If you cannot or will not do these things, you should not be working with criminal justice clients, okay? Because this is what is required to manage those cases. Judge and probation obligations. The first thing is listen and learn, okay? Open your ears and close your mouths and listen and learn about the medication and the neuroscience of addiction. You may not have seen some of the slides that are out there, but the neuroscience field knows a lot about brain chemistry. It's unbelievable what they understand about how these drugs work and the kind of medications that are going to be coming out in the coming years. We need to understand how that works. We should be listening to them. You need to carefully monitor participants for misuse or diversion. It is your responsibility to make sure that they're not taking too much, selling it, diverting it. That is your job, to stay on top of those cases. That is why I disagree entirely that this is a medical issue and we need to get these people out of the criminal justice system into the medical system. Nonsense, okay? The more severely addicted they are, the more antisocial they are, the more dangerous it is not to monitor them during the course of medication-assisted treatment. It's both systems or the case fails. It's not either or. Report side effects to the physician. Your job, if the patient seems euphoric, if the patient is sedated, if the patient seems cognitively impaired and unattentive, you report that to the physician. And it's the physician's responsibility to give you some information about what, if anything, he or she intends to do. You should also be reporting to the physician when patients are doing well, when they are what we call euthymic. Their mood seems even. Wow, the anhedonia seems to be resolving, Judge. I saw him smile the other day, okay? He seems to be attentive in group, was part of the conversation, answering questions clearly. You should be the eyes and ears of those group sessions and the court hearings with the docs. So the old adage, the old way that the docs would work over here and the criminal justice system works over here and we keep a big firm wall between them, that is not effective practice, okay? We know that that's not effective practice. It is a team approach or it's nothing. Deliver praise and encouragement to participants for adhering to their medications. Deliver willful sanctions or punitive sanctions for willful infractions such as urine tampering or low pill counts. If I don't take my medication, or if I take all my medication at one time, or I sell my medication, that is a willful proximal infraction. And a willful proximal infraction merits what? A high magnitude sanction or a low magnitude sanction? high magnitude sanction. So if you say, Bill, you had a positive drug test, and Bill said, you tested positive for marijuana, and what does Bill say? Oh, no, Judge, I swear I did. Oh, I know what happened. It's a funny story, Judge. See, I was in a car with my friends, okay? One of them broke out a joint. I told him to roll down the window. He wouldn't do it, okay? So that's your answer, all right? It's secondhand smoke. How many infractions do we now have? We have 3. Drug use, lying, and hanging out with the wrong people, right? Lying and hanging out with the wrong people are what? Proximal or distal? Proximal. So if I had just owned up to it, I'd have gotten a lower magnitude consequence, but because I lied, manipulated, and the like, it's a higher magnitude consequence. That's why these are not medical cases alone. Physicians cannot handle these cases. They don't have the power, the skill, the knowledge, the inclination, the ability to manage these cases by themselves. Do not deliver punitive sanctions for illicit drug use prior to clinical stabilization and achieving a therapeutic dose. Do not punish people for an illness. If I am suffering cravings, withdrawal, anhedonia, cognitive impairment, not only is it not necessary and will not make me better if you punish me, you will make me worse. You will increase crime, you will increase drug use if you punish people for drug use when they are clinically addicted. Okay? It is contraindicated until the clinicians tell you Doug has been free of cravings, free of withdrawal, free of anhedonia, cognitively clear for, there's no magic number, but let's say 60 days, 90 days, then you can start delivering punitive sanctions. If you're going to deliver punitive sanctions for drug use with an addict, then you are not the solution, you are the problem. Okay? Do not use jail as detox, okay? Drug court standards say specifically, we do not use jail to serve clinical or social service purposes. Why? Because jail has no clinical value at all, okay? And if somebody has already been in outpatient treatment and they relapse and you put them in jail, and I told you the only value of in-jail treatment was to get people ready for outpatient treatment, they're going in the wrong direction, okay? Jail is not detox. Jail is jail. Now, I'm not against jail. If somebody lies, cheats, manipulates, doesn't show up to treatment, proximal infractions, deliver a jail sanction. But if you deliver a high magnitude sanction for a distal infraction, it doesn't matter what you call it. You have given the wrong sanction. You make people worse. Also, not only is jail not detox, it is in many respects the opposite of detox because you reduce tolerance without reducing cravings and withdrawal. Detox reduces cravings and withdrawal. What happens when you reduce tolerance but you don't reduce cravings and withdrawal? People go out, they use, and they die. So you are scheduling death when you use jail as detox. Now, some of you are going to say, well, what if a person's using fentanyl and they're out on the street and there's no beds, there's nowhere we can send them? Okay, you got me, all right? If it's literally jail or death in the street, you got me. But I would suspect that we use jail as detox many, many, many times more than we really need to, violating the most basic fundamental laws of treatment. And provide in-service trainings to medical staff on the workings of the criminal justice system. So they should be training criminal justice people on the medications and how they work, and you should be training them on how antisocial personality disorder plays itself out in treatment. You should explain to them that some of the things the clients are saying to them might not be entirely true, okay? You need to explain to them a population they do not understand. And we're not trained to understand. Minimizing misuse and diversion. You guys are required to make sure that people don't do the things they're not supposed to do with these medications. What are some of the things you can do? Number one, observed administration. The best way to avoid misuse of drugs, diversion, selling of drugs, is to watch them take it, okay? Now, if the physician can't do observed administration, probation can do it. You can't administer the medication, but you can observe its administration. It could be a family member if they're a trusted, pro-social, sober individual. It could be a family member. It could be a treatment provider on your team. It could be a social worker. Watch them take the medication, okay? That's the best way to end, in many respects, concerns about diversion. Adherence monitoring. Do a urine test, and they better have buprenorphine on board. If I've been prescribed buprenorphine and you do a test on me and there's no buprenorphine in my urine, guess what? I wasn't taking my buprenorphine, okay? Now, you can also test for levels to see if my level's too low or too high, taking too much, but that usually requires blood samples, so I would only recommend that if someone's really, if you're really facing a revocation and a long prison sentence, you might do that, but generally speaking, that's going to be expensive and intrusive in many cases. Random callbacks. Just how people call up and they check and today the color is yellow, and if the color is yellow, that means people who have the yellow color assignment have to come in and do their drug test. You guys working in probation know how that works. Well, also they have to come in and show their pills to their probation officer, okay? And if you're supposed to have 20 pills and you only have 3, we've got a problem, all right? Less likely problem is you're going to have more than 20 because you weren't taking them. Usually they're smart enough to take them out, but if you don't have enough pills, you can do that. You guys familiar with MEMS? You know what a MEMS is? A MEMS is a medication event monitoring system. It's a cap you put on their pill jar. Every time I take a pill out of that cap, it records the date, the time, and the number of pills I took out. Therefore, you know, of course, you don't know for sure they took the pill, but you do know I didn't take 5 pills out all at once, or I didn't go a full day without taking pills out. Studies have shown that when people have these MEMS caps on it, they're more likely not only to take pills out the way they're supposed to, they're more likely to have the appropriate metabolism levels in their bloodstream. In other words, they're more likely to follow the regimen when there's a MEMS cup, especially if they also can have random callbacks. Pre-approval, full disclosure, release of information for new prescriptions. Individuals are not allowed to go out and get a new prescription for an addictive or intoxicating medication without pre-approval from probation or the court, unless, of course, it's a medical emergency. And they are required to inform the prescribing doc that they have a drug problem and that they are involved in the criminal justice system. And they are required to sign a release of information allowing the doc to share information about diagnosis, prognosis, treatment plan with the supervising judge probation. Getting a prescription without that disclosure and without that waiver is what? A proximal or a distal infraction? It's a proximal infraction, right? I chose not to tell the doc that I have a drug problem. I chose not to execute a waiver. So there would be a higher magnitude sanction, not because they got the medication, but because they didn't get the appropriate approval and the appropriate disclosure. Checking prescription drug monitoring programs. This has already been talked about, so I won't focus too much on it, but the importance of checking to make sure that your participants are not getting prescriptions from other docs for other medications that have not been approved is something it looks like in Indiana. You have some limited ability for probation and drug court to do. Not all states allow the criminal justice system to run those PDMP checks. So that's something that's an advantage you have that not everybody does. And then using abuse deterrence formulations. Methadone is you know, in the clinics is liquid form, as you heard, so it's you can't tongue liquid administration. Buprenorphine is usually a sublingual tape, or that goes to the underneath the tongue or against the cheek. Again, very difficult to take elsewhere. Vivitrol, the long-term, long-acting naltrexone. You know, you get an injection and the person's got a 30-day blockade, and now we have 30-day blockades for buprenorphine as well. These are ways of giving people medications that can wipe out, if not wipe out, then greatly reduce the risk of diversion and misuse of the medications. The reason I'm harping on this is because if the analysis is a strict scrutiny analysis, then you must have no less a restrictive alternative to saying no. And if you say, I'm not letting them have it because they're going to misuse it, when all these simple things you could do, then you did not take the least restrictive alternative. It's unconstitutional. As long as you could have done this, then your rationale is not good enough. Now, it's an open question whether this would survive a rational basis analysis. I suspect it probably would not, because this is just not that hard to do. And if there's this many ways that we can avoid misuse of the medication, then we just need to do those things rather than saying no across the board. Failure to abide by these conditions is a proximal or willful infraction and merits a higher magnitude sanction. In this circumstance, you are not punishing the person for using drugs. You are punishing the person for flouting willful rules around their drug medication use that they could have followed and chose not to follow. Okay? Choice of medication. It is not, now talking to the criminal justice people in the room, it is not your responsibility to decide what medication people should have. That's for the docs to decide. But it is your role to be a good consumer of medical information and make sure that the information you're getting from your docs is coming from a competent physician, giving competent advice. So you need to understand how a competent physician decides the choice of medications. Competent physician will consider a number of factors. Number one, patient preference. Why does that matter? Because if a patient would prefer to have buprenorphine, would rather not have methadone, they're more likely to follow through with buprenorphine, and that is a good reason, not the only reason, but a reason for giving the medication the person would prefer, because you're more likely to get adherence to that medication. Past performance in treatment. If I was on methadone 5 years ago and did very well and achieved a full year of sobriety, went off my methadone or was tapered off my methadone by the physician and relapsed, then what's the appropriate course for the physician? To put me back on methadone. If a medication worked in the past, there is a presumption that a medical treatment that worked before would be reinstated. Okay? Unless there's some reason to think the patient has built tolerance to the treatment or there's some superior treatment. So knowing the person's past response to treatment is a factor a physician would consider. On the other hand, if the physician has tried the patient on naltrexone in the past and the patient keeps relapsing, then putting the patient on naltrexone would be what? Malpractice. It's malpractice for a physician to treat you with a medication that already has shown it doesn't work. Or give you a treatment we already know it doesn't work. That's malpractice. And insurance companies won't cover it because you already tried that, it didn't work, move on. And so if the person didn't respond in the past, that is an indication for a different treatment. Age of onset and length of use. The younger you are when you start using drugs, the more likely your dopamine system is going to be upset, destabilized long term. It's going to take longer for your dopamine system to come back into normal or reasonable operation the earlier you were when you started and the longer you did it. So if you've been on methadone, if you've been a heroin addict for 25 years since you were 13, probably not the best candidate for naltrexone, okay? Probably going to need to be on an agonist medication. On the other hand, if you first started using heroin when you were 32, or you started using opioids when they were prescribed to you when you were 32, and you've been addicted to opioids for 2 years, and you're able to be detoxed, maybe naltrexone is the front-line medication because it's a short disorder, late onset. Maybe you're not going to be so sick from an agonist. Because remember, agonists don't treat cravings or withdrawal. And the lower your dopamine, the worse and the more protracted your cravings and withdrawal. So a competent physician would choose an agonist versus an antagonist based on those factors. Family history. If your mother was an addict, your father was an addict, your brother died of an overdose, chances are you have a genetic predisposition to lower levels of dopamine and a slower rebound of dopamine. You're more genetically predisposed to the disorder, therefore you are more likely to require a longer agonist type intervention. That's why we take family histories. So a physician's going to consider the fact that this is a multi-generational disorder and therefore be more likely to choose an agonist medication. Comorbid, you saw this earlier, a comorbid medical or psychiatric disorder or lack of an unstable lifestyle. If the person's got schizophrenia, bipolar disorder, post-traumatic stress disorder, anxiety disorders, in addition to addiction, they do better on agonists, on overall, generally speaking, than they do on antagonists. And that would lead your physician to move more towards a buprenorphine or methadone than naltrexone. Side effect profile. You can't get addicted to naltrexone no matter how much hard you try, okay? You can't sell it no matter how hard you try. You're not going to overdose on it. It doesn't matter if you drive. So therefore, if somebody is at risk for using too much for driving, that might mitigate away from agonist towards an antagonist. Reduced tolerance. If somebody is likely to use after being released from jail, or if somebody uses after an antagonist, that's not the medication of choice because you're probably going to get an overdose and possibly an overdose death. So do not use antagonists just for the hell of using antagonists. Judges out there who are requiring Vivitrol as their only medication in their drug courts. You could be killing people with that decision. Street value, as I said, you can't sell naltrexone. Specialized training and regulations. Almost any medical professional can give naltrexone. Most can give buprenorphine with an 8-hour training. You have to be working in specialized clinics to get methadone. And so sometimes naltrexone and buprenorphine are just easier to get to in a community. The need for progressive tapering. It takes a long time to get people off of buprenorphine or methadone. I'm not saying you should get everybody off. I'm just saying if you're moving towards tapering, it could be months, sometimes years, to taper someone off. Naltrexone has no tapering requirements. So if you're concerned about being able to do a taper down the road, that might lead you in one direction or another. Now, am I suggesting to you guys, an ambiguous diagnostic picture, if you're not sure if the person in front of you is addicted or not? Maybe he's addicted, uses a lot of opiates, I'm not really sure, he's only 22, not really sure. Well, you can't use agonists if the person's not addicted. It's illegal. And so if you're not sure, start with the antagonist, with the naltrexone, because any question about the person's clinical status. Now, did I give this to all the judges and probation officers in the room because I now want you to go out and decide who gets which medication? No. Okay? Unless you have the letters MD after your name, this is not your call. But this will let you know whether the physician you're talking to knows what he or she is talking about. And they should be able to explain, based on these kinds of factors, why they moved towards one decision or another. If they cannot or will not answer that question, find another physician, okay? Get a second opinion. Get a second opinion. Don't make the decision for yourself. That's the difference, okay? Find a competent doc. Don't decide all docs are incompetent and therefore you're not allowing it, which is what we do. We've all decided every doc out there is running a pill mill, they're all incompetent, and so we make the decisions for them. That is not true. They're not all incompetent. In fact, the vast majority of them are not, and we are not certainly competent to make those decisions for them. So it's our job to be a good consumer, a good patient, if you will, or not a patient, but a good consumer of that information, and find docs who are willing and able to make intelligent decisions and explain them to us. Well, it looks like I've only got like 2 minutes left. I guess we have time for 1 or 2 questions at most, and then, yes, you got a bike right by you.
Hi, sir. I'm a therapist. I work with a private physician. I'm from Hammond, Indiana, and I had a question. I did get that deer in the headlight look when you were talking about assessments, because I run 2 clinics for Dr. Ibecki, and we have a certain population that's coming into our clinic directly from the jails. It's a reentry program, reentry into society. And they come with the diagnoses already given to them from a licensed clinical social worker that works at the jail. The physician then does a COWS. I supervise several other therapists. Is that assessment from the jail enough, or?
So everybody heard the question. So in most, I don't know anything about the jail that you're talking about. I don't know what instruments they've used, so I can't answer you. I would say, generally speaking, most of the diagnoses coming with cases out of jails were based on clinical gut impressions, not based on standardized assessments. Even if the diagnosis is accurate, you still must assess, because someone who's been in jail for a while, I still need to know as soon as they're released whether there's a resumption of cravings and withdrawal, okay? That's what I need to know. And so even if you don't have to do a diagnostic assessment, you should be assessing cravings, withdrawal, anhedonia at every single contact with your clients. That's the first question you ask after, how you doing? I hope, how was your week? How's your cravings? Okay? Right?
Yeah, sir, yeah, we do that. We do a biopsychosocial assessment. We're very stringent in our structure. What I'm asking you is the weight of the documentation from the licensed clinical social worker in the jail setting.
I can't answer that because I don't know. I would have to review the report. If it was based on, if it's just a line that says alcohol dependence, cocaine abuse, and I don't know, but if it's a list of symptoms and the diagnostic tool that was used, then I might be more inclined to accept the diagnosis. I mean, I don't know. I can't answer you. It would depend on whether it was done competently or not. I mean, I don't know how to answer that. They're usually not. We take diagnosis very unseriously in our field, and that's the problem. Yes, sir. Blue shirt.
Hi, I'm in community corrections, and a colleague of mine brought up a good point, that a big part of probation and community corrections is public safety, and that's something that has not been brought up at all. Sometimes I really don't give a shit why the guy is using, he's using. And if he's on the street, that is, something I want to get off the street because he's not safe for the public. So how do we balance that?
I'm here to tell you that there is absolutely no tension whatsoever between public health and public safety. There never was. The number one determinant of probation failure, the number one determinant of every criminal act is substance use, the number one trigger. And so if we reduce drug use, we reduce criminal recidivism. Now, your approach is to say at some point, I don't give a shit, we're going to incapacitate. Well, no, and here's what the research is unambiguous on this point. Needless to say, if you put somebody in custody, they're not out committing crimes while they are in custody. It goes without saying. But that's called incapacitation. There's another thing called specific deterrence. Specific deterrence is the idea that now that you've learned your lesson in custody, when you get out, you won't do it again. And what you're doing is you're getting a bang from incapacitation, and and as a result, increasing the specific deterrence risk. And what all of the research has told us is you're transferring or delaying recidivism, not reducing it. That's a fact. So incapacitation gives you a short-term benefit with a long-term pain. Who else spends their whole life looking for short-term benefits and ignoring long-term pain? Our clients. And we're doing the same exact thing. And so there is no tension. And are there people I think should go away and stay away forever? Of course. Yeah, I mean, I'm not against jail. In fact, I said, willful proximal infraction, jail sanctions are appropriate. I'm here to reduce public safety costs and risks, but I measure my effects 2, 6, 8, 12 years down. And so that's the difference. It's incapacitation being wiped out by a negative effect on specific deterrence. Anyway, we are out of time and I need to go to the airport. So thank you, everybody. Appreciate your attention. Thank you.